That was a great talk, Ellen, and I think at the end of my talk I'll come back to some of the issues that you raised. But what I want to do is start us back to kind of some of the points that David was making this morning around parental interest. While I think we can acknowledge all of these programmatic and ethical challenges, there are a number of public messages that parents are starting to hear about the potential for genome sequencing. This is a Time magazine cover from just a few months ago, talking about wanting to know your future. And I think one of the reasons why Beth Tarini, who many of you may know, and I wanted to try to dig a little bit deeper into parents' interest in whole genome sequencing if it were offered through a newborn screening program. We specifically wanted to look at parents' attitudes with a baseline level of information or education. We didn't do a large education process. We didn't do a lot of informed consent around what whole genome sequencing is. We wanted to just give people just a basic set of information and find out what their baseline interest may be. This was part of the Mott Children's Hospital National Poll on Children's Health, which is a nationally representative panel that's run through Knowledge Networks, but it's run at the University of Michigan. It included a little over 1,500 parents, all of whom have at least one child under 18 living at home. Mostly white, not Hispanics, about half women, and 62% had some kind of college. This last demographic is, I think, the most important one, and we'll find out a little bit later. But 21% of these were planning on having another child within the next 5 years. So what did we tell them at the beginning of the survey? We gave them just a very, very brief introduction, talking about genetics, staying healthy and getting sick are affected by many things. Our genes, which we inherit from our parents, can affect our health and illness in many ways. Genes are made up of DNA and contain the instructions needed for our body to grow and function. All these genes in a person make up the person's genome. It is possible to study a person's entire genome. This process is called whole genome sequencing. It may give information about a person's risk of having different diseases in the future. We can have a long conversation about the ability to convey information about whole genome sequencing in a very, very small and very quick way, but we wanted to just give at least a little bit of a snapshot, a little information to parents about this before answering our questions. We then set up a newborn screening scenario where we said, imagine that you have a newborn baby. Shortly after birth, your child has blood collected for tests for serious diseases that affect infants. These tests are done as part of each state's newborn screening program. Your state newborn screening program now offers you the chance to get your child's whole genome sequenced as part of the program. You would receive the results and would not have to pay for the testing. You can decide whether or not you want the information to be part of your child's medical record. We put those particular things in this scenario because we wanted to take those constructs out of the ways in which people were answering. We absolutely acknowledge that those are important aspects, cost and medical record, that would absolutely impact someone's interest potentially. So let's just very quickly, I want to make sure we get to a discussion. What did we see, right? So we saw that 36% of parents were definitely interested, 38% were somewhat interested. So very high levels of interest from this initial set of questions. Participants who were more likely to be interested in whole genome sequencing were female, had at least some college education. The parents who were planning on having a child within the next 5 years were definitely more interested, maybe because they were thinking forward to what they possibly would want to know about their future child. And then this last one I think is also important, parents whose youngest child has at least 2 or more health conditions, right? And this kind of gets back to the idea of where whole genome sequencing, whole exome sequencing is being integrated into clinical settings right now, which is for children that have either rare or unknown or undiagnosed conditions. And so this is fairly consistent with those findings. We also asked parents to think about what factors might influence their interest. And we gave them a set of different types of factors. And we found that parents with higher levels of interests were very interested in the accuracy of the test and the potential for that information to prevent a particular disease. So this larger question about, okay, you're going to give me this information, but what can I actually do with it? Is it actionable? Will it actually help my child? Will it actually help me prevent disease in my child? Participants with lower levels of interests were more concerned about issues of privacy and that the potential results may be used to discriminate against their child. Again, not shocking. These are the kinds of things that we would expect to hear from people who may be less interested. Concerns about privacy, concerns about the ways in which the information may be used. parents in this survey also had a chance to give us some qualitative information, give us some concerns that they had. Here are just a couple quotes I just wanted to give them to kind of provide some richness of this data. About genome testing, I don't like it because it can reveal diseases that you might be predisposed to develop, yet for so many of these conditions we have no way of curing them. So what good is it to worry about something that you might or might not get? No thank you. There was also a concern about how you would integrate this information into your own life. I think whole genome sequencing sequence is wrong. You can't be sure that you're going to develop a disease or disorders. This just might be something else for hypochondriacs to worry about. And then lastly, another participant said, genome testing has many implications. As most technologies, it can be used for great purposes in preventing and warding off predisposed diseases. Yet it could also be used by unscrupulous insurance companies to deny people insurance based on what they might be predisposed to. We saw this as a kind of constant question that was raised by people, maybe talking about lack of education about GINA or lack of education about state protections, but this was clearly something that people had on their minds as they were thinking. So this is the original data that I just talked about. We also did two things, and this gets to some of the things that we've been talking about today. We asked parents that if the state wanted to also store the information and use it for health-related research, non-identifiable health-related research, would that change their interest in doing whole genome sequencing as part of newborn screening? And we saw that it did to a certain extent. For those who were in the definitely interested category, we did see a statistically significant drop. However, you still see very high interest, even when talking about health research. And I think as we think about blood spots and what we're using blood spots for, it's going to be important for us to explore this feature a little bit more. All this data will be coming into the state if we start doing this. Who can mine that data? Who can have access? Can it be used for research? And what does that mean for participants? I also wanted to say that one of the things that Bartha brought up earlier has to do with context, the importance of thinking about context. One of the things that we also did is we also had a separate sample, so we'll talk about that as a limitation in a second. We had a separate sample that we gave them a different scenario. And in this scenario, we did not put this in newborn screening, right? We took this out of the context of newborn screening and put this in the context of a follow-up or a routine checkup. During the visit, your child's doctor lets you know that they can get your child's whole genome sequence. Testing requires a small sample of blood. And if you look at the numbers, they're very, very similar. So at least when you compared these two samples, if this wasn't the same sample, we did not give parents both choices. But when you compared the sample scenarios separately, you saw very similar levels of interest in whole genome sequencing, at least in this sample. But there are some limitations. These were hypothetical cases. We were not actually offering whole genome sequencing. Parents were not given direct comparisons, so they were not able to say, I want it in newborn screening versus in my pediatrician's office. There are some limitations on the kinds of information that we were able to give parents up front. And again, it's hard to assess motivations. There's really a need for more qualitative research here to talk about what parents expect and what they would want out of this. So some of the discussions or conclusions, high level of parental interest. Our conclusion isn't that this means we should be doing this, but that rather this gives health departments and others some time to prepare for what kinds of interest there may be out there in this technology. Talking about the need for better education and counseling, addressing particular concerns that parents may have, so accuracy or issues of privacy. But I also know, so David and I were on a panel at ASBH this last year on the limits of empirical data. And I think that one of the things that we talked about is that while we may see this kind of interest, that we need to be careful about this data. We need to be careful about what this means, and think about the programmatic harms that may come from the idea of adding this to newborn screening panels. So there's clearly a need for more research and need to ask these questions from a programmatic and patient level, right? And some of these questions have already been asked by Ellen and by others. So how would patients incorporate this into their health decisions? How should they manage the kinds of results they may be getting? What about the psychosocial harms associated with uncertain or ambiguous results? Parents' rights to genetic information versus a child's right to get that information or to not get that information until they can make that decision. And clearly some of the programmatic concerns that we're going to hear about a little bit later are going to be important, and we've already heard about to a certain extent. So storage and management of genomic data, interpretation of genomic results. How do you communicate those results? The need for education and counseling, the need for follow-up. And this kind of question is has actually come up a number of times today, which is, what would states be responsible for? Who would be making the decisions on what to return and what not? And who would actually be responsible for communicating that information to patients? Would it be the providers? Would it be the states? And then just kind of general concerns that newborn screening programs may have about genomics as a replacement technology. How can you assure that the kinds of information that are currently gained through newborn screening are maintained, and that the high quality of information is maintained even with the integration of new technologies? To get back to Ellen's point, are we just talking about moving away from the kind of core goals of newborn screening programs? We've talked again a few times today about that this already happened with expanded screening with tandem mass, but are we getting to a point where we may erode the trust in newborn screening programs if people are concerned about what happens to their genomic data? We have some experience with Bloodspots that raise questions about how the public thinks about these programs. And if we want these programs to continue and to continue to provide good services to the public, we need to ask these questions about how genomics may be integrated into these programs in a way that maintains that trust and maintains that quality of service. I'll leave you with just two, I think, important questions for us to take a step back and really ask ourselves, which is, what are we really talking about here? What are we really thinking about in terms of integrating genomic technologies? Are we thinking about genomics as an adjunct technology, as something we would add on to tandem mass? Are we thinking about this as targeted screening? Are we thinking about this as just part and parcel of the newborn screening program? Or are we really talking about this as a replacement technology? Are we talking about this as something that's going to change the fundamental way we do newborn screening? Second set of questions has to do with, are we thinking about genomics as integrated into the mandatory secondary screen? Is this something that we'll just kind of keep in the kind of the way the program is run now? Or are we actually talking about what came up in both talks, which is thinking about parental choice and thinking about consent? And I think to bring David's hornless unicorn back in, I think before the unicorn can play on the playground, we need to ask these questions. We need to take a step back. We need to really think about this from a programmatic level and think about what this means for integrating genomics into these programs. I'd like to thank Beth Tarini and Rich Sharp and others who worked with us on this data. Happy to take questions.